webinar on the role of Oseltamivir in flu management. It's brought to you by Hetero Healthcare, an innovative pharmaceutical company. The journey of Hetero Healthcare began in 1993, and we have 30 years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and we have presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at SCZ Complex, Vishakhapatnam, Andhra Pradesh. Hetero Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, with pioneering in quality and innovation. And we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered and introduced Oseltamivir, Favipiravir, and Remdesivir, for which they received in the year August 2020 Award of Pharma Excellence for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got moderator Dr. Pramod Jog, and eminent speakers like Dr. Sanjay Nathu and Dr. Keyur Mahajan. Dr. Pramod Jog, as we all know, sir, is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee member GAVI CSO 2016 to 19, Chairman of Mini Recipe Module IIP, and sir is author of book Cophology. Welcome, Dr. Pramod Jog.
Thank
Dr.
you.
Keyur Mahajan is MBBS DNB Pediatrics, Pune. Sir is Diploma in Pediatric Infectious Disease, Oxford, Pune. Pediatric Infectious Disease Consultant, Pune. Welcome, Dr. Keyur Mahajan. Welcome, sir. Dr. Sanjay Nathu is MD DNB Pediatrics, MN AMS FACEE PM. Sir is currently Professor and HOD Pediatrics from March 22 till date at Srimati Kashibai Navale Medical College and General Hospital, Pune. Consultant Pediatrician, Shashwat Hospital, Kothur, Pune. Areas of interest have been pediatric pulmonology, pediatric infectious disease, pediatric emergency medicine. Sir was President of IIP Pune Branch 2021, member of Pediatric COVID Task Force Pune Division, organizing team member of numerous national and state pediatric conference training, member of National Academy of Medical Science India, fellow of Academic College of Emergency Experts, Pediatric Emergency Medicine, and has been member of Indian Academy of Pediatrics, Indian Medical Association. With this brief introduction, I hand over the session to Dr. Pramod Jog. Over to you, sir.
Thank you. Thank you. So I will start sharing the screen.
Yes, sir. Yes, sir.
Yeah. Yes. Thank you. So that. Yes. I hope you are able to see the screen properly. Yeah.
Yeah. Yes, sir.
Okay. Thank you. So good afternoon, my friends. We are going to discuss about the use of Oseltamivir in the management of flu. And this discussion related to influenza and Oseltamivir is going to be with 2 influencers in pediatrics, Dr. Sanjay Nathu and Dr. Keyur Mahajan, okay? And Dr. Pramod Jog, that is myself. You will find that the nomenclature of the influenza virus is possible to be shown in each of us names. For example, it includes the name of the virus, which includes the place of origin, the month and the year of origin, and the strain, okay? And just for information, I was the presidential strain of IIP in the year 2016. We all are aware that the monsoon is in full swing in many parts of our country. And we are also aware that the farmers are very happy, the frogs are very happy who have come out of the hibernation, and the doctors are very happy because the OPDs are in full swing, and the pharma is also very happy because the sale of the products is in full swing. With that, whenever a child comes to the OPD, and when I tell the parents that it is a viral illness and you should not worry, I myself start thinking whether it is right to say that you should not worry, because many of these viruses like H1N1, COVID, RSV, and so many others have started playing a bit tricky and naughty. See, all these viruses which I just told you, they are basically RNA viruses, and RNA viruses are known to change their structure very often. We know that there is antigenic drift and antigenic shift, which is associated with the influenza virus. And in the post-COVID period, we are witnessing waves of different viruses. I remember in 2022, when COVID pandemic started declining, slowly and gradually, other viruses started making their appearance. The measles virus, it appeared in places where measles immunization was on the lower side. Then we witnessed hand, foot, mouth disease. We witnessed respiratory syncytial virus. We witnessed adenovirus. And what we saw was even the older children were getting affected. And the OPDs are now flooded with recurrent respiratory infections by these viruses, otitis media, adenoidal enlargement, unseasonal surge in influenza, and adenovirus, which has started behaving like a bad adenovirus with varied presentations and prolonged illness. And the investigations which we usually perform, and the complete blood count and the CRP and the nasopharyngeal swab, now they have to be, interpreted in a bit cautious manner, because if you take a virus like adenovirus, the counts could be high, the CRP could be high, okay, and there could be therapeutic dilemmas related to antiviral agents, antibiotics, and so on and so forth. So it's very important that we look at all these viruses with a broader perspective. And flu, basically, I say, is the king of all these viruses. There is an entity called as flu-like illness, okay, or influenza-like illness, in short, which we call it as ILI. And I say that influenza is the father of all these influenza-like illnesses. And whenever a child is brought to my OPD today with headache, muscle pain, and weakness, and very high fever starting with chills, I usually suspect influenza. I can see older child being lifted by the father and brought to the OPD. And then from a distance, I can start suspecting whether it is likely to be influenza. Okay. So let us see one case where a 3-year-old boy who came for fever, cold, cough, and progressive breathlessness over 3 days, tachypnic with hypoxia, and X-ray picture of ARDS, and admitted to the PICU, ventilated, and received oseltamivir with supportive therapy, and turned out to be H3N2 positive from throat swab. We are all aware that influenza viruses, either H1N1 or H3N2 or type B, they are detected on the throat swab. This child had H3N2, was ventilated for 3 days, and then he was all right. Now the question is whether we could have started oseltamivir early. We all are aware that oseltamivir, an antiviral agent, works at its best when it is started early, before 48 hours in this particular course of illness. So, in a child who is previously healthy and presenting with cough, cold, and fever and progressing over 3 days, whether the treating clinician have prevented this progression, and whether every patient of cough, cold, and fever be given oseltamivir upfront, particularly in the flu season. And that is why this is confusion, that is confusion related to flu. So whether it is bacterial or viral, the respiratory infection that I'm facing, whether it is bacterial or viral. If it is viral, what is the virus? Is it rhinovirus, adenovirus, influenza? If it is influenza, whether it is H1N1 or H3N2, and whether I should start oseltamivir upfront, and whether I should give every patient an antiviral to play safe. Okay, so we are going to discuss all these issues in today's program, and we are all aware that in the monsoon we have influenza-like illnesses and H1N1 and severe acute respiratory infections to a great extent, and the incidence of influenza and the related deaths are increasing alarmingly in India. We are all aware of influenza A, influenza B, and influenza C, the three different influenza viruses, of which influenza A is responsible for epidemics, which are due to the minor antigenic variation. And there are periodic pandemics, which are due to major antigenic variation. Influenza B viruses infect only the human beings and they cause local epidemics. Remember that there have been four major global pandemics beginning from 1919 and then 1957, 1968, and 2009. And I'm sure most of us have witnessed the 2009 H1N1 pandemic. So, with that, Dr. Keyur, I would like to ask you as to what are the recent updates in the epidemiology and circulating strains of influenza viruses which are affecting the pediatric populations in India, because you are an infectious disease consultant, and I'm sure the nasopharyngeal swabs that you send in children with respiratory infections, you must be having a clear idea as to what is the current update about the epidemiology.
So currently, we are seeing rise in respiratory infection post in the monsoon season. And whenever we are sending swabs for an IPD patients, of course, we send swabs in only IPD patients. We are seeing that currently circulating strains are influenza A, and most of them are H3N2. We are getting some influenza B also, and we are getting RSV also. So right now, if we say H3N2 is at the top, then comes RSV, and then influenza B. Some cases are also being detected. So as far as influenza is concerned, H3N2 is the current major circulating strain of infections.
Thank you. And now, to tell our audience, I would just say that the people with flu, they can spread the virus to others up to about 6 feet. And these viruses are spread mainly by the droplets when people with flu cough or sneeze or talk. And the two glycoproteins which are present on the outer side of this virus, these are HA and NA. Okay. So HA, the hemagglutinin, and NA, that is neuraminidase. So when hemagglutinin, that is HA, attaches to the respiratory epithelial cell, then it facilitates the entry of the RNA of that flu virus into the respiratory epithelial cell. So hemagglutinin is important for attachment. That's why it is called the molecular key, which opens the lock to the respiratory epithelial cell. Now, what happens is that the RNA enters into the respiratory epithelial cell, and after entry, as we all know that these viruses, they replicate by using different mechanisms. And after replication, there is no point in waiting into that respiratory epithelial cell. So all of them, they want to get out of that cell and infect other respiratory epithelial cells. So all those viruses, virions, which are waiting to get out of that respiratory cells, they need something basically to cleave themselves or to separate them. Okay. And neuraminidase is the one which helps this particular exit of these viruses from one epithelial cell, respiratory epithelial cell, to the other cells. So neuraminidase is the enzyme of that virus, which is a molecular scissors, okay, which cuts all those virions and separates them so that it facilitates their exit into the respiratory secretions and then to the other respiratory epithelial cells. This is very important because the molecule oseltamivir is the one acts as a neuraminidase inhibitor. So this exit of the virions, the influenza viruses, these RNA viruses, the particles, is stopped by neuraminidase, and that is why the replication, the further spread, it is halted, and that is why the disease starts coming under control. Okay, we will discuss about it a little more, but I thought it is important that one should know the basic as to where this particular molecule acts. So, Dr. Sanjay, I wanted to ask you as to, in your experience, what are the different clinical scenarios with which these influenza viruses can present in the pediatric population? And in short, when to suspect the influenza infection?
Right. So the common presentation of the typical flu or the influenza is the ILI or influenza-like illness with history of fever, which is of acute onset, cough, cold, coryza, some sore throat, rhinorrhea, and headache. Body ache is a prominent feature, especially in influenza type B. Body ache is quite common, and you need to be aware of the picture which is going on in the community, because usually they occur in clusters. Once they start happening, many children do get infected, and hence in such a situation we should be suspecting the presence of influenza. Unusually, smaller children may present with a febrile seizure, and rarely we get complications like affection of the central nervous system or the cardiac or the heart. And vomiting and diarrhea, just like it being a viral infection, it does affect the GI system to some extent as well. So some patients do have vomiting and diarrhea, and hence most important thing would be the situation, the epidemiological situation, when we would suspect a child coming with these some symptoms to be because of the influenza.
Right. And I'm sure there could be some other members in the family who also would be affected simultaneously, because viral illnesses, as we know, as you rightly said, they are the ones which affect more than one system in the body, more than one member in the family, and more than one families in the community. So influenza virus is not an exception. And Kayur, I just wanted to know from you, these days so many patients come to the OPD with all these respiratory symptoms of fever, cough, and rhinorrhea, myalgia. And as Dr. Sanjay said, there are a few who can come with some complications like CNS complications, etc. So, is it that these complicated presentations like CNS involvement, etc., or myocarditis, are they seen right at the beginning of the illness? That means, do they present with it, or whether they come up after 3 days, 4 days, 5 days? So, have you seen such patients? So would you just elaborate a bit more as to when these children come with complications?
So what we have seen this season, there is a rise in influenza patients presenting with a febrile seizure. So they
Okay.
present as a febrile seizure. They don't present as an influenza-like illness. And when we investigate, they're having cough, cold, and everything. When we investigate, we found that they're positive. So they usually present at the initial stage only, like some febrile seizure or encephalopathy.
Okay. Okay. Now, as we can see in this table, there are different symptoms related to those respiratory viruses like fever, myalgia, cough, weakness and lack of energy, and of course, sore throat and respiratory symptoms. And during COVID times, we have experienced loss of smell and loss of taste. And as Dr. Sanjay told us, diarrhea can also be a presentation in some of these viruses. And headache is something which is very prominent in H1N1, that is influenza. And we have to be aware that, it's very difficult to differentiate all these viruses, one from other. That's why many times I always tend to say that even Rajnikant cannot differentiate these different viruses. But that's also, of course, in a jovial manner. But then the point is that we should know the emergency warning signs of flu illness. And when a child comes with very rapid breathing and cyanosis and refusal of feeds and not interacting with the parents, or sometimes being very very irritable, then one has to be very very careful. And you must inform the parents that, see, right now this child is having respiratory symptoms, but in case if you find that some of these problems are there, you should bring the child. And that's why it's better that a pediatrician tells the parents to come back. Okay, on day one it's easy to give paracetamol and say antihistaminics and maybe oseltamivir, depending on of the illness. But then you have to just see that the child and the parents, they are told that they come back after, because many times influenza behaves like a biphasic illness. Okay, and after 3 or 4 days there could be a different picture. And one should be aware that there are some complications of flu which begin with the alphabet A, like acute respiratory infection in the form of pneumonia or ARDS, as we saw in the first case, acute otitis media, absenteeism from the school or from the office, leading to loss of amdani, that is income of the parents, and antibiotic abuse, because many of our colleagues, they find it extremely difficult to decide whether it is viral or bacterial, though clinically it is possible to a great extent, but then many times it leads to antibiotic abuse. And that is why one should know that there is a definite plan of treatment of influenza, and it depends on categories like category A, B, and C, wherein category A is the one where it's not very severe. Basically, these are the children with milder symptoms, and they could be treated with rest, hydration, cough suppressants, antipyretics, and some non-steroidal anti-inflammatory agents for fever and myalgia. But it is important to note that aspirin should not be given to these children, because we know that there is a syndrome called Rye syndrome, which is likely to be precipitated in children with influenza who are given aspirin. However, some information about the antiviral drugs is a must at this particular juncture, and then we will go to the detailed discussion of management. So as I told you earlier, neuraminidase inhibitors are the ones which block the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cell. And these drugs are active against influenza A as well as B, and they are oseltamivir and zanamivir. There are another group of drugs called adamantines, which are M2 ion channel blockers. They interfere with the hydrogen ion channel activity of the influenza A virus and block the entry into the host cells. And they are active only against influenza A viruses. Okay. Giving a bit of more information about oseltamivir. Remember, it's a potent and a selective inhibitor of the neuraminidase enzyme of the influenza viruses A and B. Oseltamivir is the prodrug, which is converted to the active form oseltamivir carboxylate in the liver. It inhibits the influenza virus replication and further pathogenicity, and it prevents further spread of infection, and it is effective against all strains of influenza A and B. And this is the diagrammatic representation wherein you can see that there is a virion in the upper part of this diagram, and there is release of the new virion, which leads to infection of the other respiratory epithelial cells. And the neuraminidase inhibitors have blocked this particular virion release. And oseltamivir was the first oral neuraminidase inhibitor approved in more than 100 countries and approved by CDC and American Academy of Pediatrics. So, Dr. Keyur, what are the current recommendations for the use of oseltamivir in OPD and the IPD basis? And what are the different categories for treatment?
So, as per we know that there are guidelines for treatment of influenza-like illness. Whenever a patient comes with a complaint of influenza-like illness, like fever, of colds, fever, throat pain, body ache, headache, so we consider this patient as having some influenza-like illness. So those can be categorized like category A, B, and C. But these categories are being done because depending on this category, the treatment strategy depends. So most of the patients who come to our OPD are in category A, like those are having a milder fever, some throat pain, and with or without body ache, headache, diarrhea, vomiting. So these patients are managed only symptomatically. We give them paracetamol, adequate hydration, advise them to take rest, and monitor for development of any complications or increase in severity. We usually ask them to follow up in OPD after 48 hours or 24 to 48 hours, depending on the condition of the child. So category A, mild patients, we usually manage on OPD basis. But what we concern for us is patients with category B coming to in our OPD. Those are having fever which is high grade, usually more than 102, severe sore throat. So these patients come in category B. But category B also contains patients who are in category A, but they are high risk. Who are at high risk? Especially children who are less than 2 years of age, pregnant women, more than 65 years of age patients, chronic health issues like chronic lung diseases, chronic heart diseases, liver diseases, or any chronic illnesses, conditions which are causing immunosuppression or immunodeficiency. Such patients, even though present in category A, can be considered in category B and should be managed accordingly. And category C are patients who are having severe symptoms and having breathlessness, chest pain, severe signs like drowsiness, hypotension, So such patients we should manage on IPD basis. We need to admit them, we need to investigate them, and we need to treat them accordingly. So these categories are there. Category A, symptomatic management, no oseltamivir. Category B, which comes in higher symptoms, but they can be managed still on OPD basis. So those need oseltamivir. We may or may not investigate. Category C, we definitely need to admit them and we treat them. So basically, these are the three categories.
Right. Right. Very good. So I must inform our colleagues that whenever you come across patients with fever, cough, and cold, do not just send them back with your prescription of antibiotics and antihistaminics, but go in a bit of more detailed history and examination also. Look out for whether there are any high risk conditions. At least ask them, where they have any problem in them, whether they have any congenital heart disease, whether they have any neurological disorder. At least one or two important things I am sure our colleagues will need to see. And also, in case if they have respiratory symptoms, at least ask them whether an older child is feeling breathless or whether he has chest pain, etc. Because then it will help them to classify into category A, B, or C. And Dr. Sanjay, can you just summarize the treatment guidelines which Dr. Keyur has already started alluding to?
Sure. So category A, as Dr. Keyur has already pointed out, is a mild version of the influenza-like illness. So all we need to do is home rest at home, plenty of fluids, and paracetamol for fever. We would not be advised to start oseltamivir at all in this type of children. In category B, in addition, we need not do any test for these children either. In category B, the symptoms are a little severe, or the child may be having some underlying issue which can make him fall into category B. So here again, the testing is not required, but in such a situation, you are justified in starting antivirals. In fact, the guidelines do tell us to start antivirals, and the ideal time of starting antivirals is early, that is within 48 hours, when the efficacy is the best. Category C, of course, are going to be admitted to the hospital. They'll probably go into the ICU many of the times, and they need to be tested immediately. And symptomatic treatment, as well as the treatment which is required for the complications, along with the antiviral, is definitely required. And that is all which we need to know when we deal with the patient of influenza. That category A, no admission, no antiviral. Category B, antiviral definitely within 48 hours as soon as possible. Maybe not admission. Category C, admit and treat, and definitely start antivirals. Of course, in all these situations, if possible, we would like to isolate the patient, especially in category B and C.
Sure. You can also tell our listeners the dosages and the recommendations of oseltamivir.
Right. So adults, the standard dose is 75 milligram capsules are available, which are to be given twice daily. The usual duration is 5 days. And if we are giving a chemo prophylaxis for a close contact, then usually it is given as a 75 milligram once a day, and the duration is for around 10 days. In children, for children less than 15 kg, the dose is 60 mg per kg per day, divided twice daily. That is 30 mg once daily, and that is 2.5 ml. That is not 60 mg per kg, it is 60 mg per day. Sorry. For 15 to 23 kg, it is 90 milligram per day, divided in two doses. That is 45 milligram daily, and the syrup would come to 3.75 ml. For slightly heavier children, 23 to 40, it is 120 milligram per day. That is 60 milligram daily. That is 5 ml of the syrup daily. And more than 40, it comes like an adult treatment, 75 milligram twice daily. And if they're preferring a syrup, then 6.25 ml per dose. In small children, from 2 weeks to less than 1 year, the weight may be less. And so for any weight, the standard dose which is recommended is 3 milligram per kg twice daily.
Okay, that's great. And
Just one point I would like to add, in some situations in critically ill children or even in adults, we may need to increase the duration of the therapy, especially in confirmed cases, for more than 5 days, and that may be extended for a longer time.
okay, okay. Dr. Keyur, in your practice, do you need to prolong the duration from 5 days to 10 days? Because in adults, I have seen some physicians, they give oseltamivir for a little longer period. In fact, I have seen some adults giving more dose, not only 75 mg twice daily, but even more than that. So, have you come across such situations?
Usually in ICU, serious patients, if they are proven, as sir has already said, if they have proven influenza infection and uh, their condition is not improving or fever is prolonging, so we may continue it for 7 to 10 days also. As some adult physicians are using double doses also. So, but we are not practicing in pediatrics, but yes, they are using double doses also. They are prolonging the duration also. So, but as of now, oseltamivir is a good drug. Still, we have not encountered much resistance to oseltamivir. So, the resistance to oseltamivir is very rare. The only thing is, if viral load is high, we may need to prolong it for longer duration. That's it. If Nathu sir has to add anything.
So,
No, absolutely right.
we will come to this point again, maybe little later. So, Dr. Nathu, would you just tell us as to how early initiation of oseltamivir influence the clinical outcomes related to the duration of illness, progression to severe disease, and complication rates in children, and whether we can give oseltamivir for a child admitted with low respiratory infection with distress and H1N1 positive on day 4 or 5 of illness. That means not within the first 48 hours, but maybe if they come little late, then can we give that? So just respond to these.
Yeah. So over the years, studies have shown that the best efficacy of oseltamivir is if it is started early, that is within 48 hours preferably. And so, especially if a child or an adult comes with the type category B or category C type of symptoms, it is better to start early rather than keep on waiting or procrastinating, depending upon the epidemiological situation. Like till last month, we had a lot of cases of flu. So there was no doubt that child presenting with category B or C with a history of someone in the family also having URT or something, we would start oseltamivir quite early, definitely. Having said that, children coming to the ICU are often referred from outside and they do not reach to us within the 48 hours. But what we have seen in practice is even if we start the oseltamivir a little late, maybe day 4, day 5, even day 6 sometimes, we do get good results. And so, yes, if the child is a confirmed case of influenza, though he or she has come late, it is definitely justifiable to start oseltamivir on day 4 or day 5 or whenever we come across such a child. There's no doubt about that.
Thank you. Now, there have been many clinical trials, and they depict the benefits of empiric and the early use of oseltamivir, and particularly in patients with influenza, oseltamivir reduces the antibiotic use, the influenza-related complications, and hospitalization, and reducing the occurrence and the severity of pneumonia due to influenza by early administration of oseltamivir has been proved in many retrospective medical chart reviews of patients, and there has been a median time from symptom onset to oseltamivir administration, which was 5 days also. And there are guidelines recommendations, as we have been discussing till now, that WHO has recommended empiric therapy and treatment should be started as soon as possible. And laboratory confirmation of influenza virus infection is not necessary for the initiation of treatment. So in the epidemiological settings, when there is epidemic situation, lot many cases are being witnessed, and your colleagues are seeing so many cases, one need not wait for the report of the nasopharyngeal swab, so that you can start oseltamivir after that. No, you can start it right away. And negative lab test for H1N1 also does not exclude the diagnosis in all patients, and therefore you can give it early. Now, at this juncture, Dr. Keyur, I would like to have your opinion as to if I send this, nasopharyngeal swab for influenza virus detection, and the report comes negative, okay, then are you definitely rather sure that this is not H1N1? In fact, rather, in short, I wanted to ask you as to how good is this particular nasopharyngeal swab report, PCR test for influenza?
So the test itself is good. The PCR
Okay.
has good specificity and sensitivity. The only problem in kids is that how we take the sample. We have to take two swabs, nasopharyngeal swab and oropharyngeal swab. And in kids, it's difficult to take because we are not cooperating. Oropharyngeal swab has to be taken from posterior pharyngeal wall. Nasopharyngeal swab has to be taken from deep nasopharynx. So if there is problem in collection of those samples, then we may not get the good sensitivity. But if it is positive, it is definitely because it has good specificity. And if it is taken properly, the sensitivity of the test is also very good. So positive test is definitely positive. There are no false positives much, but negative test result, then we have to there is still possibility the child is having influenza, and still the test is negative. So we have to go clinically also. But if taken sample correctly, sent correctly, the test has good sensitivity and specificity. It's above
Okay.
90%.
Okay, that's good. So it's quite reassuring that the test is also quite specific and to a great extent sensitive. Okay, and that's why an early empiric supportive therapy and monitoring is extremely important, not in only in children but also in adults. And let us have look at a few cases wherein a child Viru came for a fever for 3 days with cold cough, and he has been on the metered dose inhaler for the last 4 months, and he has been well controlled, and he has received symptomatic treatment for this fever, cold, and cough. But after recovery, he comes back again after 3 days. And then, he has been half febrile only for a day, and again he has developed fever, and he has been active in between. The father says that, sir, why this is recurring, and this is becoming more and more frequent, and it is occurring at a short interval. So, Dr. Sanjay, will you give him an antibiotic? Will you counsel the parents? And if you do counsel, how to counsel such parents?
So the last 2, 3 months, we have been seeing this type of patients quite frequently. That child getting an upper respiratory infection and coming back again after recovery within a week, less than a week, with another episode of an upper respiratory infection. So we again need to find out the situation in the community. How many, how is the situation like the viral infections? Whether the child is attending any daycare where is likely to catch more or get exposed to more children with more viral infections, and whether the child has been completely normal in between the two infections. If he has been normal, gaining weight and doing well otherwise, we would probably ask the patients to just treat this as a fresh viral infection and again try to avoid antibiotics, but keep a close follow-up and call the child maybe a daily or alternate day, because there's always a possibility of a child who has developed an upper respiratory infection going into some sort of complication. For example, a sinusitis may be one of the complications. So we would like to keep a close follow-up, find out how the child is doing in the interfebrile period, maintain his intake hydration, and preferably give just symptomatic treatment and avoid antimicrobials at present. And also ask the parents to keep a close watch, keep a fever diary, and report back timely.
Very good. So we will definitely keep a track of the respiratory symptoms, the systemic symptoms, whether this child is going into some complications. And I'm sure you'll agree with me that over a period of about a year, as rational pediatricians, we do keep the growth charts. So to convince the parents, these growth charts are of great help, and tell the parents that the child is growing very well. So these are all viral infections which are not affecting overall well-being of the child, and then these parents to a great extent will be satisfied. Now, one important thing is that influenza virus we have been discussing a lot till now, but we should know that rhinovirus is another virus which can produce cold and sneezing, but the child in general will be fine and will not have exhaustion, and he will be in general playful. Adenovirus is a different ball game, and it comes with pharyngoconjunctival fever, may come with diarrhea, mesenteric lymphadenitis, and hemorrhagic cystitis. And respiratory syncytial virus, which is also accompanying influenza virus these days, can produce bronchiolitis, but it affects mainly children under the age of 2 years. And there are some bacteria like streptococcus, and group A beta hemolytic streptococcus is the one which comes with fever, follicular tonsillitis, and tender cervical nodes. Pneumonias will produce fever along with grunting and rapid breathing, and staphylococcal infection will produce rapid progression, and the child will be much more toxic. And organisms like mycoplasma usually affect little older child, maybe more than 5 years, though in some of these places we have seen they affect children even beyond 3 years, and they present predominantly with cough. So it's better that you know the other enemies related to these childhood respiratory infections. And this is another child, a 4-year-old child, came with cough, fever, and high grade fever for the last 5 days, and not settling with oral medicines, and on admission had tachypnea and needed oxygen support. You can obviously see that there are infiltrates on the right side of the chest on the x-ray, and the total count was 1620, and the platelets were 132,000. The liver functions were a bit deranged with SGPT of 381 and SGOT of 168, and the nasopharyngeal swab was positive for H3 and 2. So this was a child where we had influenza with low WBC count and low platelet count. So Dr. Keyur, how would you look at this particular report when you are faced with such a patient?
So any viral illness will present like similar kind of picture, like low WBC count and low platelet count. But only thing is that there are some liver enzymes are raised. So we have to keep in mind and keep looking for any other illnesses. Now, may I go to slide back, please? One slide back. So he is 4-year-old, cough, cold, fever, high grade since 5 days, not settling. So definitely he is having low respiratory tract infection. So we have to keep in mind that, and we should start Oseltamivir. We should give symptomatic management, and we have to keep watch on him. So this is LRTI with H3N2 positive. We need to start Oseltamivir straight away and give symptomatic treatment. And we need to keep a watch on the WBC count, the low platelet count. We need to monitor that.
Sure, sure. I am glad that you have clarified most of these things. Now, it is also important to note that in view of the X-ray chest and the positive report for H3 and 2, we have no doubt that this is influenza. But low WBC count and low platelet count can also be seen in children with dengue fever.
Dengue.
And
So
there
the
would
raised
be
LFT, so we should keep that.
yeah, bit of derangement of the liver functions. So it will be prudent and wise to follow up these children also. But Keyur, as an infectious disease consultant, I just wanted to ask you a difficulty, because right from my residency days, we have been saying that dengue means no respiratory symptoms. If you get a child presenting with fever, cough, and cold, we assured that it is less likely to be dengue. So do you agree with this statement, or over years this has changed? What is your experience?
So there are these are rare possibilities of co-infection of two viruses. So
Okay.
dengue and influenza co-infection are rare, but they are not impossible. So they can be possible.
Okay.
But dengue can also present like respiratory complaints if it is child is in day fifth or sixth of illness and he is having fluid leak and he is having some fluid leak in lungs. So he may present with respiratory complaints also, like some respiratory distress. And that may be due to viral infection itself, but it may be due to the fluids in the lungs. So, but co-infection of dengue and influenza, though rare, it can be a possible.
Okay, okay. So let us keep our eyes open, and depending on the clinical scenario, we can always take the decisions. Okay.
Yeah.
And we have seen another case, 3-year-old child with cough and fever not settling, the counts being normal, and the nasopharyngeal aspirate showing S3 and 2. Again, another child with cough, cold, and fever with normal counts, but CRP on the higher side, 38, with nasopharyngeal spillage showing S3 and 2. So, Dr. Sanjay, what are the factors on which clinical response to this oseltamivir, they depend?
So the most important factor, of course, is when it has been started. As we have discussed, early initiation of oseltamivir is definitely going to give to better results as compared to if you start it maybe day 3, day 4, day 5. So the one factor which is going to decide how the child is going to respond to oseltamivir is when it has been initiated. But again, I need to reinforce that that does not mean that you cannot start oseltamivir a little later. Earlier the better. But yes, even if the child comes to you on day 3, day 4 and deserves or falls in category B or C, you should start oseltamivir.
Right, that is true. Many times it so happens that we give oseltamivir to these children, and sometimes they vomit it out, and sometimes the compliance is also a bit of a problem. So in these situations, have you faced such situations first, and what are your recommendations for the parents? There are many children who are very fussy. Just as you bring the medicine spoon in front of their mouth, they will look at it and they will either thrash it off, or they will take it in the mouth and throw it. Hundreds of personalities we have seen. So to ensure that oseltamivir really remains and stays in the system, do you have any suggestions for the parents and our pediatric colleagues?
Right. So one potential problem, if at all, with oseltamivir is it tends to cause a little bit of gastritis, especially if given on an empty stomach. So we have to ensure that the parents are aware that oseltamivir needs to be given only after the child has had something orally. As far as the problem with taking the medicines is concerned, so we have to counsel the parents that they have to find a way out how they can convince the child to take the medicine. Fortunately, it is not a very difficult medicine to take. From experience, we have found out that the children do take oseltamivir quite easily. They usually do not face any problem with the taste and all those stuff. So the main thing we have to counsel is after food, and usually it does not cause any other problems as far as the side effect profile is concerned.
Right, because oseltamivir is available only in the oral form, and there is no alternative also. You cannot give it like an injection. So we have to be very, very sure about it. And of course, there was another child who came with respiratory symptoms, but the WBC count was high, CRP was very high, and he had continuous high fever and turned out to be adenovirus positive. There have been quite a few other children, which I thought would be better that our colleagues know, that so many parents are coming with such children with such reports. There is one question relating, to the antibiotic therapy. So for a child where, we are confused about the therapy, and if someone has put this child on antibiotics, and the nasopharyngeal swab turns out to be, something different, so there are many times perplexing situations, like the presentation is something else, the nasopharyngeal swab is something else, and then we are in a fix. So the question that I just wanted to ask Dr. Keyur is, whenever you are facing a child who is already on some antibiotic like amoxicillin, and then the report comes positive for, say, H3N2, then what do you do with this earlier antibiotic? Do you discontinue that or you continue that?
So if you are very sure that there is no any other secondary infection, we can discontinue that, because most of the children nowadays, because there is right now very high sort of epidemic of influenza is going on. Even in IPD patient, we don't start antibiotic immediately. If we are suspecting influenza like illness, we start them with only oseltamivir, hydration, fluids, and we send the swab. And if the swab comes positive, we continue with the oseltamivir only, and they respond nicely. So there are only few children who are not responding to oseltamivir after 48 to 72 hours, and other complications develop. And if you are suspecting there is secondary bacterial infection or some other bacterial infection, then definitely we can think of adding antibiotic. But if there is only influenza-like illness and you are admitting only for poor oral intake, high-grade fever, hydration, then there is no need of adding antibiotic. Those children can be only managed on fluids, antivirals, and supporting management. So
Right.
secondary bacterial infection is common, but not that common. So only in indoor patients, if the child is not responding to your oseltamivir after 48 to 72 hours, then definitely you can think of adding some antibiotic.
Yeah. Why I asked you this question is because, to the best of my knowledge, about 25% patients of influenza, they do have associated infection with pneumococcal organisms. And I am also aware that pneumococcus and staphylococcus are the two bacteria which can complicate influenza. So given that, as you rightly say, if the picture is clear cut and if the child is improving on oseltamivir, there is no need to add anything else. But keeping the facts that I told at the back of mind, maybe if the child is not improving and continues to be toxic, then it is prudent and wise to add antibiotics. Am I right, Kayu? right?
Yes, sir. Yes, sir. Those are
Yeah.
not improving on oseltamivir despite
Correct.
adequate dose
Yeah.
and adequate supportive management. Definitely, we can think of secondary bacterial infection. We have to search for that bacterial infection and also add antibiotic.
Right. So our colleagues, will have a clear-cut idea after this particular discussion. Okay, this is important because if the PCR is positive, either we do not give, or we stop, or do not escalate, because it's a part of antibiotic stewardship. And then Sanjay, there is a last question related to the case, and then we have a quick rapid fire for both of you. So today morning, there is a younger sib of a child who is H3N2 positive, who has come with high fever since yesterday. That means the mother says that the elder sib is already having proved H3N2, and now the younger one is having fever for the last 24 hours. So what do you do with this younger child? Do you upfront start oseltamivir, or you wait and utilize all your criteria? So how will you look at it?
So, in such a situation, even if we fall back on the criteria, this child, because of its age and the intensity of the fever is high, then is as it is goes into category B. So, in such a situation, we would not be very keen on testing the child. But yes, I would definitely think of starting oseltamivir right upfront, because the chances are very high that 8-month child is most likely going to catch the infection from the elder sib, and it is also going to be the same virus.
Right, very good. So we should all be aware that category B includes high fever and also includes age less than 2 years. So it is prudent and wise to start this particular child on oseltamivir. And now this is a rapid fire round for both of you. So we will start with Sanjay. And Sanjay, if a child gets admitted on day fourth of the illness for LRTI and comes influenza A positive, shall we start oseltamivir? Up to what day of illness it will be effective?
So yes, definitely, I would start oseltamivir, though it's the fourth day of illness. And if the child is still having symptoms, if the child is still febrile, then definitely I would go and start oseltamivir.
Great. Then Keyur, there is an elder sibling of 8-month child, which we just discussed, so we will not take up this
Yeah, we will
question.
starting. Yes,
Yeah,
sir, we will
yeah,
start.
already we start. We will take up the next question for you. What if the child is not accepting oral medicines? Is there any alternative? Sanjay, I think, told about it.
Yeah, there is no
Uh,
current alternative.
yeah,
We have to give it orally only.
we have to, yeah. Then Sanjay, will you like to tell us about prophylaxis to all the household contacts? Father, mother, grandparents?
So maybe to not all the household contacts, but definitely those who are high risk, I would definitely want to start chemoprophylaxis. For example, someone who is very old in the house, or has some underlying condition, or has some underlying other systemic involvement. For example, a chronic renal disease or something. Then definitely I would like to start chemoprophylaxis for this patient, this
Very
contact.
okay. And then Keyur, in the current situation of monsoon, a child coming with high-grade fever, severe sore throat, cough, and cold, is it an indication for starting oseltamivir upfront?
Yes, sir, because he falls in category B. So category B patients are having high grade fever, severe sore throat, cough, cold, influenza-like illness, and the current epidemic is going on. We should start with oseltamivir.
Very good. And then Sanjay, if the strain remains the same next year, of course, this is a question related to the vaccine, whether we should repeat the vaccine next year. The strain H1N1, H3N2, all are the same next year. So even then, do you suggest that the vaccine should be given again next year?
Yes, definitely. We have to repeat the vaccine because the vaccine-induced immunity tends to wane off after about 9, 10, 11 months. And so we would like to give a fresh dose, though the strains have been maybe the same.
Right. And then, Keyur, the last question is for you as to what about para-influenza viruses, whether oseltamivir works for them also.
No, oseltamivir works only for influenza viruses, no other viruses. So for para-influenza viruses, we need to give only symptomatic treatment. There is no role of oseltamivir in para-influenza virus treatment.
Wonderful. So we all are aware of the Hasta Pancha Sutri, that is, 5 rules related to the hand, like hand washing, avoiding the hand shaking, using the handkerchief, keeping other persons at a hand's distance, and avoid hand touching. These are all related for prevention of influenza as well as many other respiratory viruses. And with that, I say namaste to all of you. I am avoiding the handshake, but saying namaste. That's the best way to keep these viruses away, because all these efforts related to therapy, chemoprophylaxis, prevention, vaccination, etc., related to flu, all of them depend on you, because flu itself ends with you. And that is why your awareness and your commitment in the management is of utmost importance. With that, I stop sharing my slides and I hand over the proceedings to Dr. Prashant. Thank you.
Thank you, sir. As usual, it was a very lively session, a very wonderful session, very interactive. I'm sure the audience has benefited. Many insights, which they get out of this interaction is beyond what is mentioned in the references and journals. Very wonderful. Thank you, sir. Thanks, Dr. Sanjay. Thanks, Dr. Keir. It was lovely. As usual, it was a lovely session. And
Thank you.
thanks all the marketing and sales team of Hitro for coordination. Thanks IT teams. Thanks Nagadevi. Thanks Samriddhi. Thank you so much. Sir, you can log off.
Thank you. Thank you.
Thank you.
Thank you.
Thank you. Thank you,
Wish you
Sanjay.
very good evening. Thank you.
Okay. I think Kayur has already